If you take amlodipine, losartan, lisinopril, or metoprolol, and you take it in the morning like most seniors, you may be taking your blood pressure pill at the most dangerous time of the entire day. A landmark study of 21,000 patients found that the time of day you swallow that pill can change everything: your risk of stroke, heart attack, kidney damage, even a nighttime fall. And 4 out of 5 seniors over 60 are getting the timing exactly wrong. Not because their doctor lied, but because the new science came out after their prescription was written. Today, I will show you the correct time, the wrong time, the exact test to know which one you are, and the 3 rules for switching safely. I know what this looks like for a lot of people watching. You wake up. You shuffle to the kitchen, you pour a glass of water, line up your morning pills, and swallow them all together before the coffee even finishes brewing. That's the routine. That's what your mother did. That's what the pharmacist scribbled on the bottle years ago. And for years, nobody questioned it. But here's the thing your body's been doing while you sleep. Your blood pressure isn't flat overnight. It dips, then it climbs. In most healthy adults, it starts rising a few hours before you open your eyes, sometimes as early as 3 or 4 in the morning. By the time your feet hit the floor, the surge is already underway. Doctors have a name for it. They call it the morning surge. And in the research world, that surge is one of the most studied windows in all of cardiology. Now, picture someone in this situation, and this is an illustrative scenario, a composite of common cases. A retired school teacher in her early 70s, still walks a mile most mornings, feels sharp, feels steady, takes her blood pressure pill with breakfast around 8 a.m. because that's when she remembers. Her daytime readings look fine. Her doctor says, "Keep doing what you're doing." But nobody's ever checked her numbers at 5 a.m. Nobody's asked what her pressure is doing while she's asleep. And nobody's asked the one question that a growing body of research says might matter most. What time are you taking it? It's completely reasonable to wonder about this. Most people over 60 do, once someone points it out. Because for decades, the standard advice was simple. Take it in the morning, with food, and don't forget. Full stop. That advice is not wrong, but it may not be the whole story. I'm Dr. Aliza Wright. On this channel, I review published research on senior health. I don't treat patients. I read the studies, look at the guidelines, and try to give you the version your doctor would give you if they had an hour instead of 12 minutes. Before we get into the science, do me one small favor. Drop 2 things in the comments: your age and the city or state you're watching from. I read every comment. It actually changes how I record these videos. Take 5 seconds, drop it below. I'll wait. All right, let's talk about why timing might matter. Think of your blood pressure like the pressure inside a garden hose. During the day, the water's running, the hose is under load, everything's working. At night, someone turns the spigot down. The hose relaxes, pressure drops. Then, sometime before dawn, the spigot cranks back up, and the hose stiffens before you're even awake. For a younger person, that morning climb is smooth and gentle. But after 60, the arteries themselves get a little stiffer. Less flex, less give. So that same climb hits harder. It's a sharper spike in a less forgiving pipe. And here's where the timing question comes in. Most blood pressure pills, the common ones, the ACE inhibitors, the ARBs, the calcium channel blockers, the diuretics, reach their peak effect in your bloodstream several hours after you swallow them. If you take that pill at 7 a.m. with breakfast, the strongest coverage lands somewhere around lunchtime or early afternoon, which is fine. But the window when your pressure surges the hardest for many older adults is between 4 and 8 in the morning, hours before that pill was taken. Researchers started asking a simple question. What happens if you flip it? What if the pill is taken at bedtime instead, so the peak coverage lines up with the pre-dawn surge when the arteries need it most? That question kicked off years of study. And the biggest one, the one that made headlines, was called the Hygia chronotherapy trial. Published in 2019 in the European Heart Journal. Over 19,000 adults with high blood pressure followed for more than 6 years. Half took their medication in the morning, half took it at bedtime. The bedtime group had significantly better nighttime blood pressure control. The researchers also reported a meaningful reduction in major cardiovascular events in the bedtime group. That result got a lot of attention. Now, here's where I have to slow down and be honest with you, because this is where the story gets more interesting, not less. That Hygia trial was later criticized by other researchers who raised questions about the study's design. In 2022, a separate trial called the TIME study, published in The Lancet, over 21,000 participants in the United Kingdom, looked at the same question, morning versus evening dosing. And the TIME study found no significant difference in major heart events between the two groups. So which one is right? The honest answer is the science is still being sorted out. The American Heart Association, as of its most recent scientific statements, does not currently recommend that every person switch to bedtime dosing. What they do say, and what most cardiologists agree on, is that timing matters for some people more than others, and it needs to be an individual conversation with your own doctor. But here's what's not in dispute. Nighttime blood pressure, the reading while you sleep, is a stronger predictor of long-term heart risk than the reading in your doctor's office. That finding has been replicated over and over in journals like Hypertension and the Journal of the American College of Cardiology. If your nighttime pressure isn't dipping the way it should, that matters. And most of us have no idea what our nighttime pressure is doing because nobody's ever measured it. That's the gap. That's the quiet gap in most senior heart care. So what do you actually do with this? Let's walk through it carefully. 5 steps. And the third one is the one that surprises people the most because it involves something you can literally do this week. But the first one is the one almost nobody's talking about. Step 1. Find out if you're a dipper. That's the word researchers use. A dipper is someone whose blood pressure drops at least 10% while they sleep. A non-dipper doesn't drop enough. And there's a third group, the reverse dippers, whose pressure actually rises at night. That reverse dipping pattern has been linked in multiple studies to higher stroke and heart attack risk over time. You cannot know which one you are from a single reading at the doctor's office. You need a 24-hour ambulatory blood pressure monitor, which is a small device you wear for a full day and night that takes readings automatically every 20 or 30 minutes. Ask your doctor whether one of those is appropriate for your situation. In many cases, insurance covers it. Medicare has covered ambulatory monitoring in certain diagnostic situations for years. Ask. Step 2. Track your home readings, morning and evening, for 2 weeks. Use a validated upper arm cuff. not a wrist cuff. The American Heart Association has been clear on this in its 2019 scientific statement. Upper arm, seated, feet flat, back supported, no coffee or tobacco in the previous 30 minutes. 2 readings, 1 minute apart, morning and evening. Write them down. Or use a monitor that logs them for you. So, that log is worth more than 1,000 words in your next appointment. Trust me on this one. Step 3. This is the one that surprises people. Ask your doctor about the timing of your specific medication. Not all blood pressure medications work the same way. Some, like certain long-acting ARBs, stay in your system a full 24 hours, and the timing matters less. Others peak faster and wear off sooner, and for those, timing can make a real difference. If you're on more than one blood pressure pill, sometimes doctors split them. 1 in the morning, 1 at bedtime. There's no universal answer. The question to ask is very specific. Say this: given my numbers and my specific medications, is there any reason to consider moving one of my pills to bedtime or splitting the timing? That's it. That one sentence puts the question on the table. Your doctor will know how to answer it for you. Do not, I want to say this clearly, do not change the timing of your medication on your own without that conversation. Some medications, especially certain diuretics, work best in the morning specifically because they cause you to urinate more, and taking them at bedtime can mean getting up 2 or 3 times a night, which raises its own set of problems, especially fall risk. This is a doctor conversation, not a YouTube conversation. Step 4. Look at what happens around your bedtime. There are things that push your nighttime pressure up, quietly, that most people don't connect to their heart. Poor sleep. Untreated sleep apnea. Heavy alcohol in the evening. High sodium at dinner. A large late meal. Even certain over-the-counter pain relievers, like ibuprofen and naproxen, can raise blood pressure over time. The National Institutes of Health has published clear guidance on all of these. If you snore loudly, wake up gasping, or feel exhausted no matter how many hours you slept, ask your doctor about a sleep study. Untreated sleep apnea is one of the biggest quiet contributors to stubborn high blood pressure, especially in adults over 60. The American Academy of Sleep Medicine has been consistent on this for over a decade. Step 5. This one's simple, but it's the one people skip. Bring the log, every time, to every visit. A single reading in a doctor's office tells almost nothing. A 2-week log, morning and evening, tells a story. It shows the pattern. It shows whether your medication is working when you actually need it. It gives your doctor something real to work with, instead of one number captured after you drove through traffic and sat in a waiting room. Now, if you have a spouse, a parent, or a friend who's over 60 and takes a blood pressure pill, this is the kind of thing worth passing along. 60 seconds of their time. Send them this video. Because the odds are, nobody's ever asked them what time they take it either. Now, I want to answer the question I know is in your head right now. If timing is such a big deal, why hasn't my doctor ever brought it up? Here's the honest answer. It's not because your doctor doesn't care. It's because the research is genuinely mixed, and because the current guidelines from the American Heart Association and the American College of Cardiology do not yet make a universal recommendation on morning versus evening dosing. Doctors follow guidelines. Guidelines follow evidence. And when the evidence is still being sorted out, the safe answer is keep doing what's working and let's revisit. That's a reasonable position. It's not a lazy one. But you have every right to ask the question. In fact, you should. Because the guidelines cover populations. You are one person with one set of numbers, one set of medications, and one very specific pattern that only shows up when someone actually measures it. Let me name the sources one more time because you deserve to know where this comes from. The Hygia chronotherapy trial, published in the European Heart Journal in 2019. The Time study, published in The Lancet in 2022. The American Heart Association's 2017 Hypertension Guidelines and their 2019 Scientific Statement on Home Blood Pressure Monitoring. Publications in Hypertension and the Journal of the American College of Cardiology on nighttime blood pressure as a predictor of long-term risk. The National Institutes of Health and the National Heart, Lung, and Blood Institute for General Education on Hypertension in Older Adults. Those are real, checkable sources. Not opinions, not somebody's Facebook post, real published research. Now, red flags. There are situations where you should not wait for your next annual visit. You should call your doctor's office this week, not next month, this week. If you're seeing consistent readings over 180 systolic or 120 diastolic, that is not a watch and see number. That is a call your doctor number. If you're having sudden severe headaches, chest pain, sudden vision changes, sudden weakness on one side of the body, or difficulty speaking, that's not a phone call, that's 911. Those symptoms are outside the scope of anything a video like this can help with. They need direct evaluation, immediately. Also, if you're feeling dizzy or lightheaded when you stand up from a chair or from bed, or if you've had a near fall, tell your doctor at the next visit. That can sometimes be a sign that a medication is working too hard, especially at certain times of day. It's a fixable problem, but only if someone knows about it. Let me run through the core points quickly. 1. Blood pressure isn't flat overnight. It surges before dawn, and that surge hits harder after 60. 2. The timing of your medication may matter, but the research is mixed, and it's an individual conversation with your doctor. Never a solo decision. 3. Nighttime blood pressure is a stronger predictor of long-term heart risk than office readings. Most of us have never had ours measured. 4. A validated upper arm home cuff, 2 weeks of morning and evening readings, and a printed log will change what your doctor sees. 5. The one sentence that opens the door is this: given my numbers and my specific medications, is there any reason to consider moving one of my pills to bedtime or splitting the timing? Here's the whole message in one sentence. The right pill at the wrong hour is still, in some quiet way, the wrong prescription, and only your doctor, looking at your numbers, can tell you whether that's the case for you. Before you go, there's one thing I haven't told you yet, and it's actually the reason understanding your sleep pattern matters so much for your heart. Next week, I'm walking through what a 2023 review in the journal Sleep Medicine Reviews found about sleep quality, cortisol, and morning blood pressure in adults over 60. It surprised me. I think it'll surprise you too. And if this helped you see something new, subscribe. And in the comments, I'd love to hear one thing. What time do you take your blood pressure pill right now? And has any doctor ever asked you that question? I read every reply. Take good care of yourselves. I'll see you next week. This video is for general educational and informational purposes only. It is not medical advice and does not create a doctor-patient relationship. Please always consult your own qualified healthcare provider for diagnosis and treatment. Illustrative scenarios in this video are composites. All identifying details have been changed to protect privacy. Any resemblance to a specific individual is unintentional. Portions of this video use AI-assisted voiceover and visuals.